In our final chapter of drugs used in inflammatory or related disorder, let's look at drugs used in the treatment of asthma. We know asthma is an example of inflammatory disease consisting of two phases. The early asthmatic response, EAR, which is the bronchospasm, which comes mainly from released histamine and leukotrienes, but also the inflammatory process representing the late asthmatic response with severe bronchospasm, increased mucus secretion, and some pathological changes. I will remind you to this effect, besides the goblet cell hyperplasia we see with asthma, we also see a thickening, a hypertrophy of the bronchial smooth muscle. Now, when we look at asthma as its etiology, most often it is a type 1 hypersensitivity. Tell me a little bit about sputum cytology. You know from your pathology, the finding classically of eosinophils, a hallmark of type 1 hypersensitivity in the sputum of a patient, the finding of Charcot-Leyden crystals, the membrane basic protein of eosinophils, and the famous Kirschmann spirals, which are those mucus plug and twisted dead cells that are expectorated by our patient. Management of asthma then should include, for the early asthmatic response, bronchodilators that will provide short-term relief but will not interfere with the inflammatory process. For this, for the late asthmatic response, you need really anti-inflammatory agents in order to reduce bronchial hyperactivity and the inflammatory reactions that are ongoing. You have a diagram labeled drug actions of bronchial or smooth muscle that reminds you all of the drugs used in asthma. And you'll be very thankful to realize that most of these drugs have already been talked of. Shown at the top, what are receptors or transmitters that promote bronchospasm? Then we would like to block them. Well, we know one of the first one we encountered were muscarinic receptors to acetylcholine. Their stimulation caused bronchospasm. Blockade with the drug ipratropium would relieve that bronchospasm. Adenosine caused bronchospasm. Theophylline, the antagonist, would interfere with this. And leukotrienes also cause bronchospasm. This is where Lucas blocks their receptors or xyluton blocks their synthesis. Vice versa, if we don't want to prevent bronchoconstriction, we may want to mediate bronchodilation in an asthmatic. To mediate bronchodilation, any increased cyclic AMP in a smooth muscle, as we know well from our cardiovascular section, would relax bronchial tone. Two ways of doing this: through beta-2 stimulation with beta agonist, their receptors are GS coupled, or through phosphodiesterase inhibition with theophylline, once again, to cause bronchodilation. These drugs will see most of their uses in the acute asthma attack.